Welcome everyone to our Grampions update on drug developments and how they affect different CF mutations. We're so glad that you can join us. My name is Jeffrey Harden. I am with the Cystic Fibrosis Foundation Delaware Valley Chapter Philadelphia office, and I wanted to welcome all of you. Tonight is going to be a great night. We have two amazing physicians from one of our CF care centers to give you more information and context about these exciting drug developments and how they could potentially affect your loved ones with cystic fibrosis. And tonight's event was brought to you by our local Grampions program. So we also have the chair of our Grampions program to welcome you as well. So just to go over a couple of logistical ground rules. So we ask while our doctors are giving their presentation, if everyone can keep their lines muted just so it is easy for everyone to hear. And throughout the presentation and into the Q&A, you can use the chat feature to ask questions. If there's something in the presentation that you'd like them to repeat or clarify, you can chat during, or if you just have a question that's burning on your mind and you just want to type it out while they're talking, that's completely fine. And then after they complete their presentation, then we'll go into an open Q&A. I'll field those questions from the chat. And if you are not comfortable with the chat, then you can always just unmute your mic and just ask your question and we'll field it that way. But just for practice, I wanted to ask if everyone can look for the chat, which is that icon that looks like a speech bubble, and you can click on that to type in what eventually you'll use for your questions. But for now, if you just wanted to type in the loved one that you are here for, be there your grandchild or your child, who is a person with cystic fibrosis that you care about, and you just type in their name in the chat, and that will be your practice. And I also wanted to note that tonight's call isn't a space for you to ask individual patient-specific questions. We really refer you and your families to that one-on-one time with your care team to really go into that space. So we ask that you keep your questions of the general variety. And with that, I wanted to turn it over to the aforementioned chair of our local Grampions program, Reggie Canaris. Thank you, Reggie.
Oh, you're welcome, Jeffrey. Thank you. I want to thank everyone for joining tonight. This is a result from input that we received from a survey done after our last Grampion event. So thank you for your input, and we are trying to listen and organize things that you would be interested in. So I really appreciate the time you're giving us tonight. I really want to especially thank the physicians for their selfless time and expertise dealing with this topic. I am very interested in this topic as well. Jeffrey, I also want to give a shout out to you because without you, we wouldn't have been able to pull this all together. And I really appreciate all your support and help as the chairperson of the Grampion group for Delaware Valley. I'm particularly excited about this topic tonight. My granddaughter was just started on Trikafta, so this is very, very deep for me. I've been waiting for this for a long time, so I'd like to hear all the differences. And for me, it's going to be a good learning curve as well. So welcome, and thank you again for your time.
Great. Thank you, Reggie. And that's wonderful news about your granddaughter. It's not my first time hearing it, but every time I hear it, it just really fills up my heart. And we're so excited to get into the presentation. For more information about our local Grampions program, you can visit cff.org, or I'll also put a link in the chat so you can find out about the group that made tonight's event possible. But with that, I'd like to turn it over to, as I mentioned, our two wonderful physicians, both from Nemours AI DuPont Hospital for Children, and they're going to go through a presentation for you and answer your questions live. So everyone, welcome Dr. Aaron Chidekel and Dr. Ambika Shenoy. Thank you so much for joining us.
Thank you, everyone. Hopefully, Ambika/Dr. Shenoy will share her screen and we'll be able to get started. And I'll just start by, again, I've been caring for kids with CF at AI DuPont for 25 years, and so this certainly is an exciting time. And congratulations to all of you grandparents, new and old.
Yeah, I echo those statements. I'm Ambika Shenoy. I'm the Associate CF Center Director here at DuPont Hospital for Children, and actually been here for 10 years this year as well. And, you know, I echo Aaron's statements. What a wonderful time for the community overall. And thank you for joining us. So just to get started, we were asked just to chat a little bit about CFTR modulators. We could just set the stage of what they do, how did we get here? And so we'd like to chat about really a very brief moment, because I think that most of us are all aware of the underlying cause and mechanism of how cystic fibrosis happens. We're going to chat a little bit about the modulators themselves and how they impact how CFTR protein can function or improve its function. We'll chat about who's eligible and then the impact of CFTR modulator therapies with some stories of our patients that they have shared with us, and then get over into the Q&A.
Okay, we're going to do every other slide as best as we can. If it gets too confusing, everybody turn off your cameras, and then we'll realize right away that we're confusing everybody. So I think all of us are aware that CF is a common genetic or inherited condition. It's a recessive condition, meaning that it takes one copy of the abnormal gene from one side of the family and one copy of the abnormal gene from the other side of the family. And when there's not a sibling or a relative, as occurs in most families, most of the time this is an unsettling and unwelcome surprise. And many families affected by CF is the first time, and there's not a prior family history. The CF Foundation is an unbelievably amazing organization. And one of the exciting developments in CF is newborn screening. And if you think about newborn screening in the context of the story that we're going to be talking about tonight with the CFTR modulator medications, what newborn screening does is it allows us to identify basically all infants with CF prior to the onset of symptoms. And so you now have an infant who at the time of birth is not necessarily very symptomatic of CF. We identify them, begin their treatment, and in the case of some of the modulator therapies, are able to start them very, very early in life, in addition to the other important CF therapies that get started right at the time of birth. Not only that, we're able to get care center-based care started right away, supporting the family, supporting the baby, and supporting you as grandparents. Now, CFTR modulators are a special class of drugs. We're going to talk in a little bit more detail about this. And again, it's important that we don't lose you in the technical aspects of them. But modulators can be thought of as medications that target specific genetic types of CF and help that abnormal protein function better. These medications are not cures for CF, but rather they're protein repair therapies. And boy, did they improve the quality of life, improve symptoms, and slow disease progression. I think we understand that now. And we're learning about the potential really of the lung to heal. But for example, if somebody with CF is born with pancreatic insufficiency, the modulators are not likely, they really won't be able to change that part of the CF. Okay, Ambika, next slide.
Okay, so let's talk about the modulators themselves a little bit more. But in order to really set the stage for that, we need to think about what happens with cystic fibrosis protein or CFTR protein and where some of the mutations or changes happen that cause the downstream difficulties, or what causes this protein to not function easily. And I almost like to think of this or explain this almost as though if we were trying to build a protein, I almost think of it like a recipe to make your favorite dish or to get your favorite dish delivered. And so if we have the full recipe in its entirety, we can make something that's really good and that works really good. But if there's missing steps to it or alterations in that, that's going to change really the outcome of what we originally intended to make. So basically, if we think about CF mutation classes or where these changes happen, class 1 mutations are one where for different reasons, there is no cystic fibrosis protein or CFTR protein that is able to be made. It's almost as though if we got into a recipe book, we're missing a big chunk of it, so much so that we're just not able to move on and not able to make anything more. If we get into class 2 mutations, these are mutations, the most common one of which is F508del or delta F508, which is the most common cystic fibrosis causing mutation. We'll be chatting about that in the context of these modulators as well. But the changes that happen in the sequence lead to this protein not folding properly, which in turn marks it to say, hey, you're not looking right. We're not going to let you move on through your pathway to get to where you need to go. Almost as though you were in your kitchen or in the restaurant and they look at something, you know, the chef's quality control looks at it and says, wait a second, that's not right. I don't want to serve this. We got to put this away. We're not going to let that go out to our diner or our loved one. Class 3 mutations are that you get that protein, you have that recipe made. However, that there's a problem with activation of that protein, which is activation is going to be important for how it moves that part of salt, that chloride, into the airway to loosen up mucus or into the gut to thin and allow things to pass through the gut. Class 4 mutations are going to be abnormalities in the channel through which, or pore through which that chloride moves. Class 5 mutations are that we just don't make enough. It's just smaller in amount. And then class 6 mutations are it gets to where it needs to go, but it's pulled out or it's degraded through too quickly. So class 1, we don't have anything. We're missing too much of that recipe to make a protein. Class 2, it didn't look right. It wasn't going to function properly. We didn't want to serve it. So it's marked to not go out. It's not marked to not go to where it needs to be. And then class 3 through 6 are we get something that we can serve, but it's not going to be the same. It's not going to function the same. It's either going to be too little, it's going to go away too quick. The portion size is too little, we didn't make it big enough, or there's changes in the properties. Maybe we put too much sugar, maybe we put in a pie, for example. I'm making examples here, but just to kind of put it all into context. So this is going to be really important when we're talking about modulator therapies, because as Dr. Chidekel just mentioned, as you guys are probably aware, these new medications help to improve some of this problems or this dysfunction in the cystic fibrosis protein. And there's 2 types. The first is a corrector, and that's a medicine oftentimes that we think of that works in these class 2, where it helps to get that protein that we thought wasn't folded right, wasn't shaped properly, to where it needs to be, which is on the cell membrane, which is on the surface of the cells, looking out into the airway or into the gut or in the pancreas or in the liver or so on. And that helps to get it there. And then the next type of medicine is called a potentiator. And these medicines are for protein that's sitting where it needs to be. It helps it to stay open, or it helps it to activate so that it can stay open and move chloride into the airway or into the gut. And that allows that mucus to be thinned. I hope I haven't lost any of you guys in that analogy there, because it really does set the stage for moving forward.
Yeah, I think that was really a terrific analogy, and I think it describes what can possibly go wrong in the kitchen. My kitchen can certainly go wrong in the cells of the body, and this is why when we talk about the different modulator medications, sometimes we're only talking about a single agent, ivacaftor or Kalydeco. It just needs to push that protein to function better. And then when we talk about the other three, but really the most important one here, as I'm sure you're all aware, is the newest one, which is Trikafta. You need not only to push the protein to function better with the ivacaftor form. That's one that's common to all of the modulators, and it does the same thing in all of these modulators. It helps that protein function better. But it took a few tries to get to Trikafta, and those second and other names that you see there, lumacaftor, tezacaftor, and alexacaftor, those are the medications, as Dr. Shenoy alluded to earlier, that make that dish palatable. It makes it able to be served so it can actually be brought out of the kitchen. And the ivacaftor, once it is brought out of the kitchen, makes it taste really good. And so certain types of CF mutations will require only ivacaftor or a one-step process to make the protein to push it to work better, whereas other CF variants or mutations need more than one step, and that's where the other medications, the lumacaftor, tezacaftor, and alexacaftor, come into play. The other thing that's important to know about Trikafta as it compares to Orkambi and Symdeko is adding the second medication to get that protein through the cell's quality control mechanisms really was a game changer in terms of the effectiveness and the potency of the change in channel function that we see when we bring it to the bedside. Okay, next slide.
So just to start off a little bit with some stories and some experiences. So the first that we can chat about is the first that was approved, as you saw from the previous slide, 2011, 2012 was when ivacaftor was first approved for patients with a class 3 mutation called G551D. And this, as Dr. Chidekel mentions, one of those first several protein repair therapies that helps. It's a potentiator that helps to hold that chloride channel open, and has been having such positive impacts on our patients. So this group, Dr. Chidekel had permission to use their photos and to share, but this group of siblings used to be hospitalized on a fairly regular basis. Were on hospitalized IV antibiotics, were in to see us fairly regularly, and fortunately qualified to start ivacaftor therapy. In fact, I remember one of their admissions, I believe it was while the new DuPont pavilion was actually being built. And since they've started, really haven't been admitted to the hospital anymore at this point, and have been fairly healthy and doing really, really well. And just to share not just their story, but several others, if we look, and this is some information that one of our former fellows had gathered, if we look at the impact of ivacaftor on sweat chloride for a number of our patients, you can see improvements from the 98 to 112 range to really marked improvements down into the 50s and 60s. One actually significantly improved into a point that they wouldn't really have flagged as being screened positive for cystic fibrosis had they gotten that sweat test repeated. We can also see such improvements as well in their lung function from baseline before they started treatment in their FEV1% predicted to overall, for the majority, normal values.
If you skip back one slide, Ambika. So you can see these three sisters, and they have a different variant than G551D. That's because Kalydeco or ivacaftor is approved for a number of different of these forms of CFTR mutations, a number of different CF variants, if you will. But all of those variants result in a channel that's sleepy. And as Dr. Shenoy mentioned before, it needs to be activated with that ivacaftor so that the channel is held open, is potentiated so that the chloride can get through. The other thing that's interesting about these three sisters is that they all now have negative sweat tests. So their sweat tests went from being abnormal and consistent with CF to normal, meaning consistent with those of us who do not have CF. Two of the sisters need to take pancreatic enzymes, though, and as I mentioned before, that scarring of the pancreas was not reversible by the Kalydeco or ivacaftor, and so the two girls, young women now, still need to take pancreatic enzymes, but their lung function has remained normal for the past, well, almost 10 years now that they've been on this marvelous medication. Okay, skip ahead. Thank you. So this is just to review again to help us transition to the discussion really about Trikafta. We have ivacaftor and lumacaftor or Orkambi. We have tezacaftor and ivacaftor or Symdeko. And these medications have been available for longer now than Trikafta. And so because of that, Trikafta has not had the time to be approved for children as young as you can see there for Kalydeco. I mean, it's really remarkable what we're able to do now in clinic. As I mentioned before, we're making the diagnosis of CF based on newborn screening. And we're taking infants, hopefully maintaining their health until they're able to get on these medications. And in the case of a medicine like ivacaftor, we can start them as early as 4 months of age, very, very safely. And you can imagine that if you have a 4-month-old who is born with CF and has an abnormal sweat test and all of the clinical changes that can occur because of that, and at the age of 4 months, we can now start a drug like Kalydeco or ivacaftor, hopefully normalize their sweat test. It's very, very likely that we'll be able to prevent many of the challenges that the former generations of people living with CF had to confront because of that abnormal sweat chloride or abnormal chloride transport in their body. And so now we have Orkambi for patients who have 2 copies of the delta F or F508del mutation. And that we can start at the age of 2. You can see that we have Symdeko, which is available for people with a variety of CF mutations or variants, and we can start that at the age of 6. And now we have Trikafta, which we can also start at the age of 6, which was, again, recently approved for children 6 and up, which is very, very exciting. And it's going to be even more exciting when Trikafta bumped Symdeko and Orkambi out of the market, and we're able to use it at much, much younger ages because it's a much, much more potent CFTR modulator therapy. Next slide, Ambika, thank you.
So I think that Dr. Chidekel pretty much summed up the first portion of this, but really the drive for triple therapy was in order to help and reach people who had at least one copy of Delta F508, because as we know, probably about 60% or so of individuals have two copies of that F508 or Delta F508 mutation that causes cystic fibrosis, but there's a whole host more who have other less common mutations or have one copy of F508del and a second one that didn't really respond to Orkambi, which is lumacaftor, ivacaftor, or tezacaftor, ivacaftor, which was Symdeko. And so we can see here the lung function trend for one patient who was on the open label triple therapy study with alexacaftor, tezacaftor, ivacaftor, and you can see their improvements in their FEV1 over time, and you can see improvements in their forced vital capacity, the size of the breath that they're taking over time as well. So we can already see how the beginnings of how impactful this medication is.
So these are 2-slide series. So we have some examples of our patients at DuPont who were started on ETI because it's really hard to say alexacaftor, tezacaftor, ivacaftor. And in the world that we live in, we try to stay away from commercial names as much as possible. So ETI is the same as Trikafta. And so this is a young woman with CF. As Dr. Shenoy mentioned, she had a single copy of F508del, so was not eligible for any other modulator therapy. Prior to starting ETI, the 11 months prior, she had over 30 days in the hospital with 4 separate admissions. She was admitted to our intensive care unit because of a common cold virus that she caught in the fall. As soon as ETI became available, we started her on it. And since that time, she has also not been back in the hospital like the 3 sisters that we mentioned before. Again, her nutritional status was always good and acceptable. She still has some evidence of bacterial infection in her airway, which we need to keep an eye on. Again, these are not cures, and damaged lungs or damaged pancreases may not heal all the way. And this is a young woman who was well on the road to lung transplantation, but is now way too healthy for that. And so on the next slide, you can see her lung function, and I'm not going to overwhelm you with these data, if you will, but if you look at the first date point there, June 2019, and then just compare it to November of 2020, you can see an important improvement in both her FEV1, the amount of air, that's what the liters stands for, as well as the percent predicted FEV1, where now she's living at a just below normal, a mildly abnormal 65% of predicted, a very different place from being in lung function in the 40s and low 50s. She participates in regular activities, could probably beat me on her mountain bike, and is attending college full-time.
The next teen or young adult also has CF and has, I believe, had a single copy of F508del as well, which is why he was eligible for triple therapy as well. And he had, he has 2 copies. He'd been on other modulator therapies prior to transitioning over to ETI. And despite that, in the winters prior to beginning that treatment, he'd had 3 hospitalizations usually over a couple of weeks, and prolonged IV antibiotics. And following approval, he really hasn't needed to be hospitalized, or it's with much less frequency that he's been requiring antibiotics. However, there really hasn't been any change in his cultures, still growing the same bacteria that had been there before. And previously, with where his lung function had been, which I can show you on the following slide, there had been planning to transition to an adult center to coordinate with the possible transplant evaluation. Again, you can see, if we're not to overwhelm with numbers, but you can see that that lung function is pretty low at 30% predicted. And following the initiation, if we look, we can see that almost doubles. Probably a little over a year after starting therapy. And we can also see body mass index, the marker of nutritional status. You can see that for someone their age was pretty low, and that subsequently improved as well. And is much more functional, is employed full time, and having a much better quality of life than prior.
Yeah, I can cheat a little bit. Having just seen that young man the other day, his lung function is even better than depicted on the slide. The last patient is also a teenager, an African-American male with CF. These medications work for everyone who takes them, independent of gender or sex or race. He also was not eligible to be on a previous modulator, but was started on ETI. We actually started him in the hospital because we were worried about his clinical status. And so we admitted him to the hospital, gave him some intensive therapy, and then started him on the medication for the second week of his hospital stay. Because of that, we were able to do a sweat test while he was in the hospital. And you can see that while his sweat chloride has not decreased to the normal range, it has decreased significantly. And again, you see the theme here, because of his clinical status improving so significantly, his transplant evaluation is also on hold. And then on the next slide, again, he, like the previous patient, doubled his lung function from 30 to 60, and his nutrition improved significantly as well. And he'll be attending residential full-time college in the fall actually next month he'll be leaving for college. And that was something that was facilitated by us being able to start him on ETI therapy.
So a couple of things, we've shared our experiences, and there are numerous studies which we can show you if you'd like the references. We can put those up at the end for the trials that had come out. But there are some things that are important to realize about modulators, and you can see what an impact they've had on lung function and nutritional status and really quality of life and ability to participate. But many just common side effects are reported respiratory-wise, and the studies have been coughing or pulmonary exacerbation. From a gastrointestinal standpoint, changes in bowel habits, sometimes nausea. Some of the patients in the studies had changes in liver function testing or rise in liver function studies. So that's something that needs to be monitored over time. We've been fortunate we have not had any of those issues in our clinical practice. And we do, just so you know, routinely monitor them. And it is recommended that when you first start these therapies, you do require baseline monitoring. You need an eye exam to start off with. You need ideally baseline lung function testing and also baseline liver function testing before starting. And then liver function testing is recommended is monitored at least quarterly the first year and typically annually after that if they're doing fine. And it's important also to note when you're chatting about these things, from a family perspective, that these medicines can interact with other certain classes of medication. So it's important to know when you're on a CFTR modulator, or to talk about it with a doctor, particularly if it's not a member of your CF team that's prescribing it for you, or the pharmacist where you're picking up, to make sure that there's no interactions. In part because modulators are metabolized or can process through the liver, and it can affect the levels either to go up or down for other medications, just like certain other medications that work through that same system can change the level of these medications as well. So those are just some important thoughts. It's ideally best to take also in order to absorb it better. It's best to take with something that has some protein and fat. So to take it with food, and that just helps it overall work a little bit better.
So I think also to sort of sum up our experience, I think we've shown you that our experience has been really, I think, remarkable, particularly with ivacaftor and the early response to Alex-Tez-Iva or Trikafta. In the children on this therapy, as we've pointed out to you, there have been significant improvements in lung function, nutritional status, and really just improved quality of life. And so normalization of activities, normalization of symptoms, maybe still need to take your enzymes, but significant improvement in GI symptoms as well. Many patients do note, as Dr. Shenoy mentioned, some coughing in the first few days or week or so after starting therapy, which tends to improve with time and airway clearance, as well as other routine medications. And then again, because of the change in the fluid and the inflammatory environment in the bowel, a number of patients have also reported change in sort of symptoms there, and we're just discussing those on a case-by-case basis. We have not, thankfully, had to stop any of our patients because of side effects or other medical concerns related to these modulator medications. So while these are oral medications, the side effect profile has been really very, very, very minimal and quite positive. And then the CF Foundation and their guidelines, again, we continue to follow those guidelines. We have to follow those guidelines to the benefit of our patients, to the benefit of your grandkids. And so even with the improvements that we're seeing in patients taking these highly effective CFTR modulator drugs, the ongoing relationship with the care center and center team, the importance of that can't be emphasized enough.
And just along those lines too, all of the original studies that were done, and to date the information still available, is the most benefit is when these are used in addition to your routine CF treatment. So this doesn't replace any of your usual CF care regimen at this time. And so just to sort of summarize before we move into the Q&A section, with modulator therapies available at present, probably about 90% or so of people who live with CF, have CF, will have access to some of these, or one of these, at least one of these therapies that we've just talked about. And we, I think in the community, are all well aware that that's still not 100%. And that I will say that the CF Foundation, again, and just how it's a tremendous support, has committed a huge amount of money, research, funding, and support to investigating new treatments or options, or really approaches for those who are not eligible for these modulators at this time. And, you know, I hope as that happens and as we learn more, you don't know, some of that might actually help everybody while we're trying to make sure that nobody gets left behind. And it's certainly important that people who are not eligible for treatments right now should not feel left out at this point. We've certainly always worked as a community and, you know, starting with your local sort of community and care center, but as a national, international community as well. And we all want to make sure everybody gets the support and care that they need. And I can briefly slash, these are some of those modulator trials by age that had gotten the original, if someone is interested. And I'm going to stop presenting right now so that we can chat a little bit more informally.
Well, I want to be the first to just say thank you so much for that presentation. I thought that was incredibly informative, and I hope that everyone on the call agrees. As Doctors Shenoy and Chidekel said, now the rest of the time is yours. So this is a space that you can ask any questions you may have about the presentation or another question. So feel free to put that question in the chat, or as Reggie has done, just raise your hand. So take it away, Reggie.
So I just have a question. As I said, you know, I'm also a nurse and I've seen the progress and amazing, only, you know, also personal experience with siblings years ago. Been living with CF all my life. And I can't believe on a professional level, the strides that have come, and it's only thanks to the work that you guys do and the CF Foundation funding and everything else. So it's really very exciting. And as I said, my granddaughter just started on ETI, if you want to call it. I'll call it ETI on Saturday. So I'm very anxious to see that. I've been waiting. She's 9 years old now. I do have a question about, I have an adult daughter who is 33 years old, and she has, you know, obviously the same mutation that we all share, but she also has a nonsense, what they always used to, she was diagnosed at 13 with atypical CF. So I'm just wondering down the lines, if they start, you know, getting these meds to work on quote unquote the nonsense mutations, if somebody that was once classified as atypical CF would be considered for the therapies as well, in your opinion.
Okay, so I can take the first part of that, and then Ambika can chime in as well. By a nonsense mutation, we usually mean an X mutation or a stop mutation. Am I interpreting that correctly?
I'm not sure. It's a 3905 INST and 5T allele.
Okay. So that is not a quote unquote X allele, if you will. But at the end of the day, for a CFTR modulator to function, it has to have some protein to repair. And so if there is a stop mutation, an X mutation, that's the genetic code for stop, don't make any more protein, there's no protein, so there's no protein to repair. And sometimes in these insertion and deletion variants, there is so much inserted or so much deleted that no protein is made. And so that would be sort of the first question for your daughter and her doctors is there protein that's being made?
Okay.
The 5T allele is interesting in that it results in a reduced number of CFTR protein transcripts. So protein is made, but in a reduced number. And there may be some some experience there in using a drug like ivacaftor for somebody who has a 5T. And so there may be some relevance there for her to talk with her care team about. Again, it's going back in time. We're probably from, or we're certainly same generation. Usually when we talk about somebody with quote unquote atypical or non-classic CF, I hope that that's a sort of a milder form of the condition or of the disease. And so a number of my patients who have grown up with quote unquote non-classic or atypical CF are followed at CF centers where the discussion as to whether or not to start modulator therapy is part of their ongoing care should they ever develop symptoms. So it was actually a trickier question than you probably imagined, and so I hope I did it some justice. Ambika, anything to add?
I would just add in general, there's a couple of different places that you can look up if your loved one's mutation is eligible for modulator therapy. If you go on there's a couple different, one is the cftr2.org website, which is a CF Foundation gene consortium with Johns Hopkins that looks at sort of the impact of different cystic fibrosis mutations. It's not meant to be diagnostic, just so you know, and this should always be done in conjunction, in discussion with your care team. Okay, but that's one place that it's pretty regularly updated, and it will oftentimes say what therapies that you would be eligible for. I believe the pharmaceutical company website, if you under the drug name itself, oftentimes lists the mutations. So if there's something, so a couple of things that's important, I think, just identifying information, which is good to know offhand when you have CF. One is, what are your mutations? Two, what's your lung function? Three is oftentimes also your nutritional status, your body mass index, or so on, just as sort of markers overall. And these are often things that you'll read about in studies of what impact these medicines are having. And then there are studies, research studies ongoing around the country for those what are called theratyping studies. Oftentimes that's looking at cells from a patient and trying to look at them more in a laboratory setting, but to look and see what the baseline sort of cystic fibrosis or CFTR protein function is, and if application of these medications, at least in the lab in a petri dish, helps improve function. And I will say some of the expanded mutations that these modulators work on were based on those sort of studies too. And that's something that your care team can help with also, or help identify places if that's something that someone's interested in.
Thank you for that.
Great. Thank you for that question, Reggie. That's a great start, I thought. I did see a couple of hands up, and we are going to try to get to all of you in the 9 minutes that we have left. I did see what I thought might be a quick and easy question in the chat. It looks like it was from Loretta, and I direct that to both of you. The question is, may they have a copy of the slides?
Of course.
Okay, great. Well, I'll be happy to share those afterwards. And then
So
I
Jeff,
saw.
what we'll do is we'll send a clean copy. We'll take the picture off, and we'll blah blah blah.
Okay, perfect.
Yep.
Yeah.
But absolutely, yep.
Perfect. And then Dan and Pam, I saw that you had your hand up. So if you want to unmute yourself and ask, go ahead.
Hi. This is very new to us. Our daughter was born in granddaughter, sorry, was born December of 2019, and then obviously we all spent quarantine of 2020. So she hasn't had a lot of family socialization because mommy had been in quarantine with her. But I have a two-part question. One about, is there talk of the FDA possibly lowering the age on the Trikafta, because she was told that she is eligible for it since she and my son-in-law have, my daughter and son-in-law have different mutations. Is there talk about that being lowered, the age range?
Okay, so that's a one-part question, but that's
Yeah.
that's
No, I
answer.
have a second part.
Boy, as soon as we get the studies done, boy, as soon as we get the studies done, boy, as soon as we get the studies done,
Okay.
the goal, I mean, we have Kalydeco or ivacaftor starting at 4 months. And at DuPont, we did some of the infant studies for that. So the foundation and the company that makes these medications is highly motivated to bring these drugs to as young of individuals as possible. So yes, the answer is as soon as the studies are done, we'll be able to get those medications started in infancy.
The second is about stools and flatus with my granddaughter. Her stools are so foul. They smell so terrible. And is that something that continues their entire life because of the medications? Or I worry about her socially when she goes to school. You know, I know that's far away and she's got 4 years to go here, but I worry about the simple things like that. I mean, is that something that can be controlled, or are they always going to smell so bad? And I hate to say that to my daughter because I don't want to get her upset or self-conscious about it, but it's just something we talk about as a side.
You're muted, Ambika.
Thank you. I think I'd gotten over that after all these virtual events and things by this point. I was going to say most of our patients lead such pretty full and fulfilling lives and participate in so many different activities. I think the hard part, just in general, when you're young and when you're going, is that you're feeding probably more often and pretty regularly. Baby stooling patterns vary. Remember, when people have CF, you don't absorb all of those nutrients as well. And sometimes medications, and this is why you're followed more frequently too, but medications need to be adjusted to help with some of that digestion and absorption. And I admit, as kids get older, I have not noticed those sorts of issues and have really not had people who've experienced such complaints down the line. And I think maybe perhaps some of the other family members and even Dr. Chidekel, Jeffrey, if you want to comment as well. But I think that's something over time that we would anticipate.
Yeah, the therapy for fat malabsorption or pancreatic insufficiency will be individualized, and just make sure that gets brought up with the care team, because there may be some ways to quote unquote mitigate it, but it certainly should improve, as Dr. Shenoy mentioned, as the sort of the eating schedule and the sort of the reliance on whether it be a formula or milk-based diet in sort of infancy and early childhood diversifies.
Seems silly to even ask the question, considering so many other more life aspects of it, that are life and death. But it's just, I appreciate
day-to-day symptoms, though, right? That's probably more affecting here and now.
Thank you.
Great. And if I can ask everyone, once you've asked your question, if it's asked and answered, if you can lower your hand, just so I can tell if it's just that original question or if you actually have a follow-up question. And then I did see, Pat, you raised your hand.
Yes. My granddaughter is 7 now, but she was diagnosed when she was born about a month into it. And we all went down to the hospital to talk to a nutritionist and all. But she has a rare mutation. And last January of 2021, my daughter-in-law was caused was called by a technician or somebody in their office that said that she was eligible for Chidekel. So she's been on that since, and I don't see her so much because she lives in Jersey and because of the pandemic and all, but she seems to be doing very well. And she just finished first grade, and her school had plexiglass around 3 sides, and she was fine. She only had to stay home one time. She's very social, so she would be devastated if she couldn't be in school. And she only had to stay one time because the teacher in second grade taught a brother of one of her friends. So she stayed home, and then some people sent their kids to school sick, so they kept her home for Thursday and Friday. Then she went back Monday, but she loves school and she does really well, and she's very social. But my daughter-in-law said she can't detect any, she sees improvement. I don't know, like the numbers you talked about, like respiration rate or the lung capacity and all. I don't know those numbers from her, but I assume they're pretty good because they don't. In fact, I think she goes to DuPont. I don't know, maybe you're one of you or her doctor. Her name's Chloe Bruce, and she's 7. And from what I can see, she looks like a picture of health, and she's doing very well. So she's very active. She plays 2 sports. I think she plays a softball and I think the other one's lacrosse. And I've seen videos of her running to keep up with that ball. She does really well. So, but you answered some of my questions about the continuing the normal therapy. I mean, I noticed she does the vest, and she takes her enzyme because she has the pancreas involved too. So, and she's got a very good appetite since she got older. When she was younger, she wouldn't go to the bathroom when she woke up, and they had to beg her to go to the bathroom. But now she's fine. She was so busy playing that she didn't want to go to the bathroom. But now she's good. So I think everything you're doing is wonderful, and I learned a lot today too. And I would enjoy a copy of the slides too, because I taught biology, so I understand the genetics of it, and I understand, but I didn't know about the modulators. I knew it was protein, but it's interesting to hear about it. But she has a rare mutation. I really don't remember what it is. I thought it had letters in it. It wasn't numbers, but it had letters. So, but I know about deletions and nonsense codons and stop codons. I did DNA renaturation for my master's degree, so I know about DNA and how wonderful it is. So, but anyway, thank you very much tonight for all your information.
Thank you for sharing too.
Yeah. Yes, thank
my
you, Pat.
Son, and she was diagnosed that early. That was the first child, and she has a brother now, and he doesn't have it. But I don't even know if he's a carrier. I don't think they had him tested yet. But I know they had to have their DNA done after they said that she could go. She's on Chidekel, and she seems good with it, But she always said to her mother, "Why doesn't Shep have treatment like I do?" And he sits next to her every time she has it. So they're buddies. So
one of the things that I heard in your comments there, Pat, was not being familiar with the numbers that our doctors were sharing about lung function.
Yeah.
And so I thought that might be a good point to end on, and something that Grampions on this call, other folks that are listening to it later, could just take into their conversations with their kids and how they're understanding what happens in the care center visit. Now, when you put up the examples, you would have where you were showing lung function over time, a number, a slash, another number, a slash, and then a third number. So can you just kind of give us like the layman's explanation of those, what those numbers are and how you're expressing them?
Sure. So many times, when sweat tests are typically completed, they're completed in duplicate. So usually one on each. So you have measurements from each arm, and that sort of acts like a quality control mechanism in and of itself. So typically for the numbers that we mentioned with sweat tests, the number and then the slash and then the other number just represent each site. And then typically what we have for many of our patients have baseline and then try to look and see again after a period of time after starting modulator therapy to see if there's an improvement in CFTR function, which is what the sweat test actually directly measures. And that's been shown, then that's partly based on studies that were done, for example, for ivacaftor, for the ETI therapy as well, where there were significant improvements noted in sweat chloride testing, not as much based on the studies for lumacaftor, ivacaftor, or teza-iva either. And then as far as lung function goes, typically those are shown as either an absolute value, meaning the actual size of the breath or how much volume was actually exhaled, and then and oftentimes we also look at that as what's called a percent predicted. Those percent predicteds are based on the age, the ethnic background, and height of the patient or the individual, because those are all qualities that correlate really with, again, the size of the breath that you are expected to be able to take. And then again, in repetition to try to see and trend over time. And that's often something that you do routinely as part of CF care over time as well, not just with modulator treatments. And again, I think the other part that's important to realize is that some people have varying levels of comfort in what they share or what they think people want to know also. And that might affect, or maybe not, but that might also impact sometimes the discussions and so on.
Yeah, we talk to parents and families and older teens with CF, and as Dr. Shenoy mentioned before, it's very important to know your variants or your quote unquote mutations, to know your lung function. Usually that is the FEV1% predicted, and to know your nutrition, and that's most often measured in the body mass index. And so those are parameters that some are typical for the population, right? So we're all nagged about our body mass indices when we go to our doctors. Anybody with a respiratory condition, asthma or something else, has lung function measured, and so the FEV1% predicted is going to be an important parameter there. And then what's unique to CF is the individual variants or genetic background for that patient. And then tonight, the fourth parameter is medications. And so we started that discussion in, probably the most complex place, but thank you for hanging in there with us.
Great. Well, I wanted to be respectful of everybody's time. I know that we did run a couple of minutes over, and so Dr. Shenoy and Dr. Chidekel, do you have time for one final question?
Sure. One final question or two, maybe.
So Loretta asked, what new developments are underway that get you excited?
So I think Dr. Shenoy did a nice job introducing the concept that we have 90% of people covered with highly effective modulator therapy, but we need solutions for the remaining 10% of individuals with CF. And those are the developments that get me excited and remind me of when I first started out in CF, and we didn't even have pulmozyme. And so the new developments for the remaining 10% are what get me excited for, well, I hate to say it, the next 25 years of my career.
Yeah, I totally agree.
That's great. And Pat, I think that you raised your hand earlier as they were speaking. Did you have a final question?
I just wanted to ask, if a student is away at college, are they expected to check in with a doctor every so months, or how does that work if they're away, like in a different state?
Well, that's individualized. I mean, when we send our young adults off to college, we strongly encourage them to get in touch with the local care center. And I mean, usually there is one, right? Unless the college is really sort of in the middle of nowhere. And then this is specific to my practice. I don't speak for other physicians and what they do. Every single one of my patients who goes off to college gets my cell phone number. And if they need something, they can text me. I saw a young woman today, not with CF, but she's going to be starting at the Albany College of Pharmacy, and she got my cell phone number. And that, again, that's just unique to my practice.
Well, I knew a woman whose son was going to college. This was years ago when Chloe was first diagnosed, and she wanted to move to California because that's where he was going to school. And he said, "Mom, I'm a big boy. I know what to do. I know treatment. I know what to do. You know, you stay here with Dad. You stay here, not moving out with me." So
That's for sure.
They do mature and they do learn what they have to do. Yeah.
That's great. Okay, well, why don't we wrap it up there? This has been an amazing night. Thank you so much, Dr. Chidekel. Thank you, Dr. Shenoy. That was very informative. Thank you, everyone, for your questions and for joining us tonight. And thank you, Reggie, for everything that you do for our program. So as promised, we'll share some information after this call. And we look forward to seeing you all again sometime soon. I hope that you enjoy the rest of your summer. Thanks again.
Thank you,
Thank
John.
Thanks, guys.
It was awesome. Really appreciate your help. Thank you.